Yeah. Well, hello, everyone. I'm Victor Zhao. I'm the president of the National Academy of Medicine. And good morning to everyone on the West Coast. I'm very disappointed I can't be with you in person. Earlier, I heard that you've got a sunny weather. Well, you know what? I just have to do it vicariously. But I'm delighted to join you virtually to kick off this important meeting. First, the collaborative. Since 2017, National Academy of Medicine's Clinician Well-Being Collaborative has convened, published, and shaped national conversation on clinician burnout, stress, and related issues. Our goals over the years have been to improve the understanding of the challenges and to advance evidence-based solutions to improve patient care by caring for the caregiver. So health technologies from electronic health record to ambient listening are shaping the daily work of clinicians for better or for worse. In the NAM's consensus report and the national plan that you may and may not be aware of, certainly our members are, the collaboratives stress the importance of engaging clinicians in the design and deployment of health IT and digital technology to show effectiveness, efficiency, usability, and safety of technology. So back in 2022, our collaborative convened to discuss the impact of health IT on clinicians. And we heard from health systems that have successfully deployed tools to reduce provider burden. But we also examined national barriers to catalyzing wider implementation of such innovation. Many of those barriers persist to date, including interoperability, adequate federal funding support deployment. So today, given the fast-paced evolution of AI, there's even more pressure on health systems and policymakers to address these barriers in the future. Now, we all know that AI is undoubtedly one of the hottest topics of healthcare today, sparking great excitement, optimism, but also uncertainty about its potential to revolutionize the way we deliver and experience care. In particular, AI holds incredible promise to reduce burden on clinicians. Well, however, it's important to acknowledge that AI is not a monolith. So we really need to examine the utility of specific tools while recognizing that new technology, no matter how innovative, will come up with AI scribes, tools to transcribe patient encounters and leverage machine learning and natural language processing to summarize clinical conversation and produce documentation. Well, these two, while they aim to reduce burden, we must ask if they are. One, are they achieving the promise? And two, for which condition are they effective? So you all know that some data show doctors think that notes produced by AI scribes still require a lot of editing and rewriting, and they haven't saved them any time. But on the other hand, one study of same AI tool, Ambient, for example, implemented with nurses showed great significant time savings per inbox message, resulting in overall time savings. So what do we believe in? Well, we must ensure that AI is optimally designed to meet the needs of all types of clinicians. So that's part of our conversation today, right? Would it save time? How is it designed? And can it done in such a way that really help us to meet the needs? And in addition to time saving, tools must be able to reduce cognitive burden, which is a key component of clinician well-being. This underscores the critical need to, one, having clarity of what data indicate and two, carefully balance the benefits and drawbacks of current AI tools, especially in the clinical practice. If implemented without careful consideration, AI technology can risk exacerbating challenges like clinician burnout. On the other hand, if thoughtfully integrated with the intended user in mind, AI could become a powerful ally, streamlining tasks, enhancing decision-making, and most importantly, creating space for clinicians to focus on what truly matters, building relationship with patients and improving care quality. So I want to briefly touch on 4 key considerations related to AI as an impact on healthcare workforce. First, we must assess the efficacy and time-saving potential AI applications, which tools truly save time and improve efficiency. And understanding the current landscape and anticipating how these tools may evolve is really essential. Second, we must ensure that implementation of this technology empowers healthcare workers. If AI can indeed save time, how should the tool be plugged into the workflow of clinicians to reap the benefits for their entire care team? How will workflow need to change? And moreover, will this newfound efficiency allow doctors and nurses to spend more time with patients, strengthen relationship, and providing better care? Or with health system instead use AI as an excuse to further burden already strained workforce by saying, hey, you got more time, see more patients. So this is really important in this discussion that we're looking at AI forward. And the third point I want to make is that we must consider which scenarios AI can act as an appropriate proxy for work of professionals. Can AI truly replicate or replace the work of humans in meaningful ways? Or are there use cases that risk undermining patient care by neglecting the invaluable patient perspective, human perspective, that only healthcare workers can provide? The last thing we want is to exacerbate feelings of patient healthcare workers' alienation. And finally, what about the cost and payment? You know, I hear that only some select hospitals, maybe those are financially well-resourced, are willing to bear the cost and burden of these technologies for the clinicians. So there's widening digital equity gap between institutions and clinicians who are capable of financially supporting AI and those who have not. And imagine if this cost is transferred to clinicians. They have to bear the cost, while in fact what they're trying to do is improve patient care. So we need to really understand all those issues. And finally, we need to demystify the cost of investing AI so it is less risky for hospitals to integrate AI and to avoid additional costs for already overburdened workforce. Wow, lots of issues on there. That's why we're having this meeting. Because, you know, if you really want to take a step back and think about with such hype in AI, we need to have a clear strategic action to ensure the thoughtful implementation of AI in healthcare. You know, some of us are becoming more skeptical than others. But by the end of the day, I want people to leave with a deeper and better understanding of the issues at this meeting. The real question is, will everybody be able to agree on the holy grail use of AI in healthcare? Or is much more research and learning is needed? This meeting is the beginning of many discussions to come. We recognize and collaborate how important this issue is. That's why I give credit for the steering committee, for our co-chair, for An, to jump on this issue to say, let's start addressing this now. Now, so I want to thank University of California, San Diego. They have recognized the need in NAM to examine these priorities. So I want to thank the Joan and Erwin Jacobs Center for Health Innovation and the UCSD Health Office of Physician Wellness for making this event possible. I want to include Patty Mason, the CEO, Sonia Ramamurthy, the Interim Director of Physician Wellness, Chris Kane, and his Wellness Oversight Committee. We have 4 exciting sessions lined up today, which will provide insight how AI applications can support health workers' well-being, highlighting potential use cases, address key stakeholder considerations, and identify ways to avoid common pitfalls in the digital transformation. I'm also excited to hear from my good friend Tom Ferris, whom I've known from Mass General Brigham days, who was the former National Director of Transformation at NHS England. And of course, he's bringing lots of experience with him. And we thank him, Tim. Thank you, Tim, for your contribution and for speaking to us. The planning committee for today's workshop is Christopher Longhurst and Jackie Gerhardt. You heard Jackie earlier on, and they consist of STEAM experts who generously volunteered the time, expertise to design this meeting. And the work, of course, has been supported by my dedicated staff and staff across the academies, including Antron, Rita Ahmed, Bram Bond, Ash Ranka, and Samantha Phillips. Their commitment and efforts deserve the greatest gratitude. Can you help me give them a round of applause? Okay, without further delay, let me turn over to Chris, who will add their final opening comments to kick off today's meeting. Thank you.
Thank you very much, Dr. Zhao. I want to provide a warm in-person welcome. Unfortunately, not as warm as we would hope. I apologize for the weather. It's supposed to hit 65 today. But it does feel like 70 if you're standing in the sun. For those of you staying through tomorrow, it will be a little bit warmer. The good news, though, is that the wintertime is the best time for sunsets. And so I have to tell you, I'm equally excited today about these 4 sessions, learning from all of you, and what I expect to be an absolutely extraordinary sunset. And our 4:30 adjournment has been scheduled around that sunset. So please make sure you join us. You see here our learning objectives for the day, and I'm particularly excited about this because, as Dr. Zhao suggested, there's a lot of evidence coming to light, and I think the most single clear point is that AI is not a silver bullet, right? There is a lot of potential in AI to help us, but we're learning more and more that what seemed like absolutely unbelievable kind of data about improvement in time and experience as the peer-reviewed literature is coming out is backing up a little bit. In fact, just last week, our colleagues from Atrium and Adventist Health published a large study showing that the AI scribes had had a significant improvement on physician experience, but not a significant improvement on time spent. Our colleagues from Stanford published another smaller study suggesting that there was an improvement in perception of time, though not actual time improvement, which one could argue may be equally important. So presenting that available research on the impacts of AI and health care worker well-being is critically important. Exploring use cases where applications of AI have demonstrated clear or promising benefits for healthcare worker well-being, and then discussing how stakeholders can navigate and prevent digital transformation pitfalls in the current and future healthcare environment are our objectives for today's meeting. And again, really appreciate everybody joining, both those online and those who can join us here in San Diego. I'd also like to thank the planning committee. And so we've got a roster here we'll put up on the screen. But I do want to, in particular, thank Dr. Bill Mobley, who's the director of the Sanford Institute for Empathy and Compassion here at UC San Diego, as well as Habib, Habib, raise your hand, is in the corner, has put together a lot of these logistics, along with the rest of the planning committee. So thank you to my colleagues on this planning committee. Thank you particularly to Dr. Jackie Gerhardt for being my co-chair on this effort. And we're incredibly excited for today. And so before I turn this over to Dr. Ferris, I'll just remind those of us joining us.
Chris?
Yep, Dr. Zhao.
Can you ask An to send me a link? I'm only seeing you and An. I'm not getting the overarching link. If you can send me a link to the meeting.
I think that they're hearing you, so links should be coming. And
Okay.
for those of you joining us online, you can submit questions throughout the day using the Slido underneath the live stream, which Dr. Zhao, I expect you'll be able to see soon. So again, thank you to members of the Planning Committee, and Dr. Ferris, we're looking forward to your opening talk. Thank you.
Good morning, everyone. Well, it's a real pleasure to be here to see some old friends and some new faces. I'm excited to participate in this event. I can't think of a more important topic, especially as a father whose daughter was just accepted at medical school, and so is looking forward to going to medical school. And I'll tell you, a lot of people have asked me, tell me, well, so you were unsuccessful at dissuading her from going into medicine? And I said, I don't share your views about the future, and I hope to, by the end of this, that I will get there. I need to do some housekeeping first. So I was told to do a very thorough conflicts review. So I have a staff appointment at Mass General. I'm an adjunct professor at Harvard. Those might not be conflicts, but I currently advise 2 venture capital firms, Morningside, which is Gerald Chan, as in the Chan School of Public Health, and F Prime, which is Fidelity's venture capital firm. I specifically advise them in the area of health information technology and AI. I also sit on the advisory board of Codemetrics. Codemetrics is a company that I founded when I was the CEO of the Mass General Physicians Organizations, because I couldn't believe that we employed 360 people to do our billing, and now the MGPO employs about half that using technology that is now part of a company. I sit on the advisory board, and I do have some equity in that company, full disclosure. And then finally, I advise the UK Minister of Health on health policy issues, mostly related to technology, both in healthcare and in social care. And I have oversight over the Working Committee on AI in healthcare. So, prior to the pandemic, my team at Mass General published several studies on physician burnout. We wanted to take a broken windows approach. And so we asked physicians very specifically, what are the things that are burdening you that you're most complaining about? 8 out of the top 10 were technology related. That was a surprise to us, but not a big surprise. It makes a lot of sense. But we learned something. So first of all, documentation was the number one, by far the number one. And so we put in place, actually, it's sort of funny to think about it now, but we put in place ambient documentation. This was 5 years before LLMs were invented. But we did it, you may have heard about this, there was a couple companies in India where during the night, while you were asleep, they would listen to the transcription or read the dragon text of your encounter and then turn that into a physician's note. I will say that there weren't, when I was walking through the halls of Mass General, there weren't very many things that I did where I was thanked openly by the doctors. That was definitely one of them. Now, about 20% of doctors didn't find much benefit from it. I'll tell you, it was very specialty specific. The hand surgeons at Mass General had macros for every patient they saw, and they just pressed one button and their note was complete. I think they had to adjust whether it was the right hand or the left hand, right? But whereas the psychiatrists and the primary care doctors, where the burden is much higher, were incredibly thankful. But as these things always go, the important lesson for me for this group was actually what happened after. Because once the physicians had this, it didn't take very long before they forgot what life was like before they had it, right? And there was a lot of discontent among the physicians, as there is now. And it became clear to me, sort of obvious, that the broken windows approach was important, but there were larger issues at play here than just technology, obviously. My opinion is that the larger issues, if I had to pick 3 words, 3 phrases, they would be increasing complexity of care, the associated clinical risk, and physician agency. Those would be sort of my top ones. Different people have different top ones. The increasing complexity of care is actually a product of our own making. It is, in fact, a product of an incredible success. And that success is the advancement of science in the creation of diagnostics and therapeutics. When I started practicing medicine 35 years ago, there were many conditions where patients were admitted to the hospital. I would see someone and I didn't have, and I could care for them, I could give them consolation, I could explain their issue, but I didn't have something to do, I didn't have something to order, because there was no therapy for whatever it was. That is just incredibly rare now. And that complexity is new to us. It's a boiling the frog. We don't perceive this happening over time. But for example, just last year, the FDA approved over 400 new indications for therapies. When I started practicing medicine, they were approving about 40 a year. Now it's over 400 a year. That complexity is one of the two main ingredients that is contributing to the massive cognitive load and burden on people delivering healthcare. The second one is, of course, something that I'm personally involved in. I was born in the very last demographic month of the baby boom. So I know I don't look like it, but I'm a boomer. And the baby boom is creating an extraordinary issue for the delivery of healthcare, because all of those older people, like me, have multiple chronic conditions, 4 on average at the age of 60, 8 on average at the age of 80. So you take the fact that we have all these therapies now. There were a lot of things we just couldn't treat before. And the burden of illness, and it is that demographic wave combined with innovation that is creating, to my way of thinking, the extraordinary cognitive load problem on our physicians. And not just our physicians, I will say this is across all nurses, allied health professionals. So, and so sorting through the complexity of all this, so my patients with multimorbidity and all of the medications they're on, sorting the interactions of those medications, like what could one be doing to the other, and I'll use these words quite purposefully, it is not humanly possible. It is not humanly possible to sort through that complexity. No human brain has the capacity to sort through that complexity for an individual patient, I will submit. And so last week, I met a young cardiologist practicing in Florida, and he told me a now familiar story. He quit working for his private practice cardiology group in Florida, which, by the way, I don't know, back in my day, they were basically among the best paid doctors on the planet. And he quit his job for that private practice cardiology group and now works as a cardiologist at the VA. And he is loving life. He has a young family, 3 young kids. His wife works. He has no administrative overhead. He isn't being chased by anyone in the practice about billing and seeing more patients. He sees as many patients as he feels comfortable with. He made a work-life balance choice to forego 50% of his income, and he now currently sees about 25% of the patient volume that he was seeing before. And he thinks that, what a great trade-off. That is totally understandable, but it makes me worried. It makes me worried because physicians all over the country are making the decision to cut their time and see fewer patients so they can go back to caring for people. At the exact same time that we have this demographic wave with all this innovation that has created an extraordinary demand for healthcare, extraordinary demand. So what are we going to do about that? And I want to emphasize the point here because the U.S. is showing signs to me of a looming capacity crisis. So I just spent 3 years in the NHS, which, and a plug, I wrote a paper that published in the New England Journal 3 weeks ago about the lessons from the NHS. But all of the things that were happening a decade ago in the NHS are happening today in the United States. So waiting times to see a specialist are up dramatically in the United States over the past, it's a boiling the frog thing. It's getting a little worse every year. It's never a crisis, but it's getting worse every year. Many people don't know this, but despite our high costs in the US, we have the third lowest number of acute beds per 1,000 of any OECD country. Like, how is that possible? We have a shortage of acute beds. So what was happening in the NHS 10 years ago is they started having boarders in there. They called them the A&E. We call them the ED. Well, guess what's happening in the United States? In every urban medical center in the United States. At Mass General, when I came down as an intern, there were 7 or 8 patients waiting in the emergency department to be admitted. On average, every single day for the past 2 years at Mass General, there's been over 100 patients waiting for a bed. Think about that. That's 10% of the bed base of that hospital. Okay? That is happening in urban medical centers throughout the United States. Okay? So we've got an interesting situation developing here. Again, very slowly, but it's inexorable. And we're not even close. The baby boom sort of caps out in 2045. Right? That's when it starts to level off. So we have increasing pressure, demographic pressure, until about 2045. Different demographers will answer that question differently. I don't sweat the difference. So will technology solve the problem? That's another way of saying what Victor was asking at the beginning. And so will we move from a one-to-one, basically a one-to-one service delivery model, to a one-to-many service delivery model? Will people use autonomous services to get advice and navigate the health system? Will physician work be more focused on the exceptions and also on personally caring for people and less on administrative work? So in my job as head of technology at the NHS, and now in my work advising venture capital firms, I regularly meet with senior leaders in major tech firms as well as tech entrepreneurs. And I get to test their wares. I get the preview of a lot of the stuff they're working on. I feel very lucky to do that. And yes, there is a lot of hype. But yes, it is extraordinarily impressive. I have tried multiple times to break LLM diagnostic machines, and I couldn't. Like, they are really, really good. And do I spend time worrying about hallucinations? You know, there's been a lot published about hallucinations in generative AI models. Let me just say, I have sat on the wards in hospitals listening to other physicians on the phone with patients and other doctors. I've heard a lot of hallucinations. And in fact, one of the issues here is, one of the great things about AI is you make a mistake, you train it, it never makes that mistake again, ever. Like, it can't make that mistake again. Is that true of people? And another thing, again, I'm not overhyping here, but everything an AI model does, it records. Can we say that about what we do in healthcare? Like, did we actually know what happened? Well, I'll tell you what my nurse said to me when I had an ambient documentation. I said, so what do you think of my notes now? And she said, you mean, what do I think about the fact that I now actually know what you said to the patient? I was like, okay, thanks for the honesty, right? So, so I want to be clear in terms of the health information technology that a lot has improved in this process of, you know, electronic patient records. A lot has improved. So most patients in the United States today can see pretty much all of their records at their fingertips 24/7. That didn't exist when I started practicing medicine, and it has changed everything for the better. Also, closed-loop prescribing. Prescribing is a much, much, much safer activity than it used to be, all because of the electronic patient record and the associated health information technology. So I don't want to say that there hasn't been major steps forward, but it has come at a big cost, and the cost has been mostly on the clinicians who have to use those systems. It is about what is called in the tech world the UX. I think the next decade will be a decade where health information technology becomes the big story, and that actually the practice of medicine in any profession will look dramatically different than the way it does today. And the reason I say that is I don't have a lot of confidence actually that physicians are going to, and other health professionals are going to be rapid adopters of this stuff. Actually, I have very little confidence. But you know who's going to be rapid adopters of this stuff? Patients. Because I can tell you, as those access problems mount, and you have an option to take a picture of that skin lesion and get it diagnosed with 99% specificity and sensitivity, which is what 3 different companies can provide, FDA approved drugs. Well, why aren't those systems currently widely used in the United States? Rhetorical question. Okay, obviously, because it undermines the business practices of dermatologists. Full stop. Okay? And that's why. But patients won't accept the fact that there is a solution, a low-cost, high-quality solution that exists out there that they don't have access to. They will get access to it. I am quite confident of that. And I just hope, and this is what I wanted to close on, is, well, actually, I had a couple more things to say. Do I have time? How am I doing on time? A couple more things? 5 minutes, okay. I'll come to the hope at the end. So how is this going to happen? So I see 4 categories of AI-based health information technology. I wrote this in a paper which we will send out the link to, called Unit Cost and Hope. And those 4 categories are basically, the first one is clinical verticals. There are now thousands of cool things in a clinical vertical. So there are headphones made by a company that, I don't know where and I don't know what the name of it was, but I've used them. And basically you put on these headphones and whatever your ear problem is, it will diagnose it. Okay? That takes a couple seconds. You can do it anywhere. Okay? There are stethoscopes that are effectively echocardiograms, right? You actually can get valve information from a stethoscope. Like there are literally hundreds of these that sit within a clinical vertical. And by the way, they all use AI, but it's not the kind of AI that people worry about. This is all AI with narrow outcomes, so it is trained on a data set. It can't hallucinate, just to be clear. The hallucinations are something that come with the type of AI, which are the LLMs. Those are the clinical verticals, and they will change things. By the way, there is a company, again, FDA approved, that you can take as a parent 2 3-minute videos of your 2-year-old, and it will tell you whether or not your child has autism. Do you know how long it takes to get in to see a pediatric neurologist in the United States today? 18 months. Those 18 months are critical, is a critical time for the brains of infants. Okay? Why isn't that immediately adopted everywhere? I hope we spend some time talking about that during this symposium. So the second is what I call cross-cutting software. So it goes across everywhere, and that ambient documentation is just one of those. But I'll say the real big one here is clinical decision support, whether that's for the patient, answering your questions, And a lot of the ambient documentation companies are moving into this space because the bar for doing ambient documentation now is quite low. I have a friend who just opened up ChatGPT, had it transcribe a visit with a patient, and the ChatGPT note was pretty much the same as 3 other of the major software vendors. And he's like, oh, so why am I buying this software, right? The third is operational analytics. AI is going to produce an enormous amount of benefit in operational analytics. Things that, because of how complicated our healthcare delivery system is, that we don't even know are bottlenecks and problems, AI can figure out quite easily. Of all of these, the most transformative thing by far is clinical decision support. So I've already said, honestly, I'm not worried about the hallucinations problem, enough said on that. I am worried, though, about one big trend. I talked about this very briefly. I had a sentence on this in the paper, in the New England Journal. I am worried about the effect of venture capital, private equity, the tech giants, and the insurance giants. They are all in this space. They are heavily investing in AI because they see that a major undermining of the established delivery of healthcare. They see much lower cost, higher quality care, and those organizations are being incredibly aggressive about the acquisition of technology that can seriously undermine the delivery of healthcare. But the problem is, and I will just say, they're doing great stuff, the technology itself, but where they're headed is they want as big a chunk as possible of the $3.5 trillion that is the healthcare market. And boy, pay attention to what they're doing, because they know what they're doing, and they know that if they offer something of high quality to patients, patients will vote with their feet. And they will not be going to the doctors employed in the standard old-fashioned way. They will go to doctors who are overseeing LLMs and technology that gives them the answer that they want right now and is a high-quality answer. So I am worried about that. And then I'm worried about, as a profession, you know, any of the professions, showing leadership. I'm ending. I'm there. I can tell you're. But I think it is on the professions to show leadership in this moment, because of the things are going to start shifting quite quickly, I think, in the next several years. And that leadership means 2 things to me. It means being aggressive about adopting things that are clearly good for patients. I'll just say, I don't see that happening now in the medical world. I do not see aggressive adoption of clearly beneficial technology. I see guild protectionism, honestly. That's what I see. And the other thing is, having said that, we need to be assertive about adopting it. We also, if we are assertive about adopting it, we will also be in a better position to make sure that we're taking the fruit, and to quote my favorite author, Chaucer, taketh the fruit and let the chaff be still. Like, make sure that we're getting the good parts of it. And this time when we do health technology, let's make sure that the UX really works for the people delivering healthcare, as opposed to the last time during the High-Tech Act where that did not happen. So I am optimistic about the future. Technology will help us successfully address our growing capacity challenges. And we may actually finally have something that was first written about in the mid-1970s. This idea is sort of the city on the hill of the learning health system, where a health system actually, as it does its work, learns how to do its work better. That has always been out of reach because of the practical hurdles of the management of that process. Actually, a learning health system is now within reach because of AI. And that is, to me, an incredibly exciting prospect for both my daughter going into medicine, but also, I hope, my grandchildren and their children. In the receipt of higher quality, lower cost, very efficient healthcare. So thank you very much. And do I sit down now? Yes, I do.
I'll have the panelists come and join me here, please. So I'm Lottie Derby. I'm Chief Wellbeing Officer and Senior Associate Dean for faculty at University of Colorado School of Medicine. It's my pleasure to serve as the moderator for this session here. I'm just going to do a very brief introduction of the panelists. There are various QR codes in the building here where you can scan and see the complete bios of everybody who's going to be part of this session. So I'm joined by Christopher Longhurst, who we already heard from this morning, Chief Medical Officer, Chief Digital Officer at UC San Diego. Margaret Losovetsky, who's the Vice President of Digital Health Innovations for the American Medical Association. Ken Cato, who's Professor of Informatics at University of Pennsylvania, a nurse scientist for pediatric data and analysis and at the Children's Hospital of Philadelphia. And then lastly, Jackie Gerhardt, who's the Chief Medical Officer and Vice President of Clinical Informatics at Epic, and a family medicine doc, as we heard. So I'm going to go ahead and, whoops, we did advance the slides. Let's see here. So I just have a few comments here this morning. This is my disclosure, a bit of a back downward trajectory as we have moved further away from the pandemic. Of course, this is not a phenomenon that's limited to physicians. We are here talking about in healthcare workers. Doesn't matter if you're a pharmacist, a dentist, an advanced practice professional, a trainee. We see the same story, unfortunately, again and again. And just to remind us all, we are here to drive action forward. To drive that action, we have to be able to articulate the so what. Why does it matter that there's a high prevalence of burnout in healthcare workers? Well, for one, it threatens the very premise that we are all here to give patient care. We know that physicians and nurses who are more burnt out have less commitment to lowering the cost of care. We know that they engage more in unprofessional behaviors, that they have lower empathy, less compassion, are less accountable to sort of holding us all to the standards of medicine. And importantly, we know that docs who have high levels of burnout are twice as likely to be involved in medical malpractice litigation suit, they're twice as likely to say they've committed a major medical error. The level of burnout in nurses and doctors in the ICU is an independent predictor of patient mortality. The level of burnout in our nurses is an independent predictor of hospital-associated infections. And obviously, there are mental health consequences. We have already talked about problems with access to care. Doctors who are burnt out are twice as likely to leave their place of employment, many of whom are not seeking another job in healthcare. If we don't leave, we reduce the time taking care of patients, which is another way that impacts access to care. And that's happening all too often as people are finding the release valve, right? Finding a way to still care for patients in our dysfunctional system. And we all know that the drivers are complex, or else we wouldn't have been at it, since 2017 or 2018 when we all started this journey together. And we blame the electronic health record, right? Myself, as a general internist practicing at Lowry, as well as many of my colleagues, if only we could fix the electronic health record. And certainly in studies of physicians, as well as in studies of nurses, we have given our electronic health record a pretty bad usability grade. But it's not all about the electronic health record. It's also simply about the volume of work that comes through the electronic health record. This is from UC Health, the system in which I deliver care. Just that we were all receiving before the pandemic about 53,000 messages a month. You can see now that it's over 183,000 messages a month. There's been growth in the system, yes, but not nearly to that proportion. You talk to any of my primary care colleagues, they're on average getting between 30 to 50 in-basket messages a day, on top of seeing patients every 20 to 30 minutes. And then, of course, there are my colleagues, our colleagues who practice hospital medicine. Recent publication from Marisha Burden at University of Colorado and her colleagues demonstrating that for a hospitalist shift, they're getting 130 secure chat messages in one shift. They're trying to also hold the hands of patients, talk to families, coordinate care. So we're here today together to really talk about, can AI improve healthcare workforce well-being? How can it improve it? What could be the unintended negative consequences? How do we adapt it? When do we adopt it? Where's it going to work, right? All these sorts of really important questions. We are having this conversation in a setting where the press is having this conversation. We're having it in the setting where the AAMC and the ACGME and the rest of the alphabet soup are having this conversation. So I look really forward to spending the day with you today as well as tomorrow to really sort out how can we move forward together to really impact the lives of healthcare workers and, importantly, the patients for whom we provide care. So with that, I'm going to go ahead and transition it over to Christopher Longhurst for his comments.
Terrific. Well, thank you for that perfect setup for a conversation today. So a little bit of introduction. I wear a number of different hats. I get to help lead the Office for the Chief Medical Officer, our IT portfolio, including our CIO and information security. And so I sit really at the junction of exactly what you're talking about, which is this epidemic of messages and after-hours work and non-reimbursed kind of clinical time that is driving our clinicians nuts and contributing to a sense of lack of well-being. And I want to commend Dr. Chris Kane, the CEO of our physician group, who along with our CEO, Patty, really undertook an effort to measure wellness throughout all of our clinicians. One of the areas where we found the highest correlation between burnout and well-being and technology use was a single question, which was, do you have somebody who helps you answer messages in the electronic health record? Because we've had the exact same experience that UC Health and others have had, which is an incredible rise in messages during the pandemic. In fact, our primary care physicians on average do get about 30 messages, and it turns out they spend 30 seconds to a minute answering each one of those messages. And so I'm going to back up a little bit to the fall of 2022 when ChatGPT was released, and a colleague of mine called and had been playing with it and feeding it patient messages off of a Reddit forum. And the responses were surprisingly good. And he called me up and said, I'm going to try measuring it, and will you help study this? And I said, absolutely. I'll spend my Christmas break ranking 200 patient questions and responses. And unfortunately, the clickbait headlines that came out of this were that the chatbot was smarter and more empathetic than doctors. And that wasn't my takeaway. My takeaway was that actually the chatbot could tee up really accurate responses that came with a tone of empathy that our clinicians were actually in some cases envious of. But I saw this as an opportunity to implement a tool to help solve this problem of the epidemic of messages. And so I called up my colleague, Dr. Gerhardt here at our EHR vendor and others, and we agreed that we would pilot this as one of the first places to implement generative AI in our electronic health record. So fast forward, April of 2023, we were announced as one of the first 2 pilots in the country, along with Stanford and eventually University of Wisconsin. And thanks to generous donation from Erwin and Joe Jacobs, we had the resources not only to implement this, but to actually measure what happened. And that's really important because that's something I think we're all hoping we can do, but don't always have the resources to actually do. And credit to Dr. Ming Tai Seal, who's sitting in the front here. Ming helped lead a group that very rigorously evaluated in a randomized QI study the impact on early adopters versus late adopters, because we couldn't get any of our primary care doctors to say that they weren't going to adopt it. So it was early versus late. What did we find? Well, first of all, it absolutely reduced cognitive burden. And that's sort of from the Journal of No-Brainers, which is that it's much easier to face sort of the edit on the screen or the copy on the screen and edit it than it is to start blank. Secondly, it did not significantly reduce time spent. So before the AI, it took about 30 seconds to see that patient message, maybe use a dot phrase, your labs are normal, et cetera. Or maybe it's too complicated a question and you say, please come see me in person or let's schedule a televisit. After the AI, now you have this 3 or 4 paragraph response. And it still took about 30 seconds to edit that response and make it sound like it was coming from your tone and send it off. So it wasn't reducing time, but it was improving well-being and reducing cognitive load. And in fact, our colleagues at Stanford who studied this at the same time did measure burnout using the standardized inventory, and they found that it decreased burnout. There was a third, though, really important lesson that I want to make sure doesn't get lost, which is when we were implementing this, we ensured that we were adhering to our AI governance principles, one of which is transparency. And we often think about that as transparency of the algorithms that are used to develop or implement, or transparency of data sets. But in this case, a really important question was asked about transparency with our patients when we were using this tool. And I'll say that my initial response and some of our clinicians is, hey, we don't have like a disclaimer when we use dot phrases, so like, why does this need a disclaimer? It's still being edited by the doctor. But representatives for our patient family committee said, AI is different, it's scary. And if we want to maximize trust with our patients, we should maximize transparency, and that's what we did. So anytime a physician clicks that button that says start with draft message, we put a disclaimer at the bottom that says this message was generated automatically and reviewed and edited by, and it puts your doctor's name in. I think that was actually one of the most important things that we did. That got coverage in the New York Times just last month because there are now almost 200 health systems using this functionality across the US, representing tens, if not hundreds of thousands of physicians. And it's implemented in a highly variable way. Some places have done this. All the University of California hospitals have implemented and are using this transparent approach. Others have not and defended it in that New York Times article. But as we move forward with these tools to transform the way we're delivering care, because I agree 100% with Dr. Ferris that this is going to totally change the way that we practice medicine and deliver health care, I think we've got to do this in a way that not only measures it rigorously, but partners with our patients and families on how we do that. So I want to finish my comments just by sharing the denouement of the story, which is that we're continuing to roll this out and have had conversations with our nursing union because by request our nurses wanted access to this. And so it was with great interest I read a fantastic article from University of Colorado where Dr. C.T. Lin and colleagues published the effect of these draft replies, and they found actually the Net Promoter Score in physicians was net negative. Remember, that's -100 to +100. Medical assistants, it was also net negative. But the average Net Promoter Score among nurses was about 58. And there was a great accompanying editorial by Dr. Lisa Rottenstein and Bob Wachter, where they identified that protocolized kind of situations where this AI is most likely to help, it's probably going to be the most helpful, and that it may actually help nursing workflow more than others. And so we're continuing to learn together in that learning health system on what's working and what isn't. And just over the last 12 and 18 months, we've learned a ton together in partnership with our vendor and other colleagues. And that's really, I think, the most important set of comments moving forward, is that we need to continue rigorously evaluating what's working, what isn't, because it's not a silver bullet. So thank you. Look forward to the panel.
Thank you. Hi, I was going to say good morning. It's 11:59, so it's still morning. Good morning, everyone. My name is Margaret Lozowatsky. I am a pediatric hospitalist. I still see patients a few times a month, and I am the Vice President of Digital Health for the American Medical Association, and I like to say a recovering CMIO, CHIO. I've been doing healthcare informatics for most of my career, and as I joined the AMA, my focus is on how to support physicians, because we are the AMA, we focus on physicians, in their use of technology, so all clinical technologies. And this is a very exciting topic for us as technology is evolving very, very quickly. And so what I wanted to do is take a little bit of a step back and talk about some of the research that we have done at the AMA when it comes to well-being, and some high-level thoughts on what we believe is the path forward to implementing these technologies successfully. And I really appreciate Dr. Longhurst's comments on the fact that we have a lot to learn. We are very much in the infancy of utilizing these technologies in healthcare. And so we found, as was said before, that today about 48% of physicians report some level of burnout. So it's a little bit better than it was at the height of the pandemic, but man, we have a long way to go. We talk a lot about the different forces that are impacting physicians today, and we know that those forces are impacting us on a daily basis. So things like prior auth documentation, reporting requirements, technology often being at the top of the list of what we report as the cause of our burnout, and yet we recognize that we're experiencing all these other forces through technology. And so it's really important for us to really get to the root of the challenges so that we can start to address those challenges. While we know that the user interfaces sometimes have had opportunities, we also recognize that all of these other things that we're experiencing through that technology lens may have a very significant impact on our well-being. And so we think a lot about what are the AI tools that can help, right? That's the question that we're trying to solve here. And at the AMA, we have developed this alternative conceptualization of AI. We call it augmented intelligence. And what that means is that we recognize that technology is at a place right now where we don't think it can be autonomous. So we don't believe that today an AI bot can take care of patients independently. And while we may at some point get to that place, it's going to be really important for us to understand that that clinical judgment of our colleagues is at the center of all of this, and is the reason that we went into medicine, to take care of patients. And so that, as we think about well-being, is a really critical aspect of how we look at these technologies. And we also are starting to understand which are the areas where these tools can be most impactful, as has been highlighted, and I think is really important. It may not be where we think it's going to be impactful. So we all know the in-basket is probably the number one thing we hear our clinicians say is the cause of their burnout. And yet, while we are seeing anecdotal evidence that there is improvement, we're also not seeing a time change in the time that's spent responding to these messages. And so as we continue to evaluate these tools, we're going to need to really think about where can we have the most impact. Of course, ambient has been discussed. I did want to talk a little bit about this concept of cognitive burden, and that has been brought up by Dr. Harris here, which I think is often at the root of many of our struggles, because we talked about all these forces coming at us and the amount of data that we're having to digest. I was at a meeting in DC talking about AI with a lot of leaders, and somebody brought up a really impactful statistic where he said that 50 years ago, if you were taking care of an ICU patient, there were 7 pieces of data on that ICU patient. And 7 factorial would be the combination of all of those pieces of data, which none of us could really process, right? No human brain can do that. Today, it's about 1,300 pieces of data on every ICU patient. Now, 1,300 factorial will break your calculator. And we are asking our clinicians to process that information and to make clinical decisions, which we know is not possible. And so to me, that's where the power of AI is really going to show most of its impact, is helping to decrease that cognitive burden and doing the computational work that our human brains are not able to do. And what does that look like in the clinical settings? We know that a lot of the burden is processing information within our charts. So some of these chart search functionalities that will be able to present the right information to the right person at the right time, all the R's of clinical decision support, so that when a dermatologist is looking at it, they'll get information relative to them. When a neurologist is looking at it, they'll get the information that they need. Some of these data trend challenges, so what I described, all of these data points that we're not able to necessarily trend in our heads, the power of the AI tools is that they'll be able to show those trends and to help us make clinical decisions. Again, that augmentative concept where the computer presents the right information and we continue to make clinical decisions. So thinking about these tools as a co-pilot, similarly to how we use them in other settings. I also wanted to talk a little bit about some of the challenges, and that was a question that was asked. How do we integrate these tools successfully? We know that there's a lot of potential here. When we ask physicians, and we've done a lot of research on this, and we're actually going to redo the research to make sure that we continue to stay current, but when we ask them, what are you looking for in your technology? The things that they say is they want the technology to function seamlessly. No surprise, right? Just like you use your iPhone and you know it's going to tell you what you need. They want the technology to help enable their ability to care for patients. They want to make sure it works for their specialty because we know that the needs are very different. And they also often talk about the fact that they want to see that the technology is actually helping have improvements in outcomes for their patients, because again, ultimately we're there for the needs of the patient. So how do we do this? We know that we need to be very thoughtful about integrating those technologies into workflows. And yet what we've often found is that we concentrate on the processes that we know. So when we were implementing EHRs, we said, this is my form, put it in the computer. This is the way I do things, don't mess with that. And so instead of re-envisioning the workflow and how we could potentially care for patients with these new technologies, what we did is we took the paper and we put it in the computer. We don't take web pages and put them into a smartphone without redesigning them. And yet we did exactly that with a lot of our technologies. So as we think about integrating these AI tools, there's going to be a lot of hard work to really re-envision the way that we deliver care and question what is the appropriate workflow. Do we need to have new tools for the way we document, or do we re-envision the way that we write notes today so that they serve the purpose that we think they should in the future? And finally, what I want to conclude with is the fact that there's a lot of hype right now about AI. There's a lot of excitement, rightfully so, because it has a lot of potential. And what we need to recognize is that technology is not the limitation for the changes that we are thinking about. So much of this depends on the people and the process. And it is a huge culture shift across our organizations to recognize that it is on us, all of us as clinical leaders, to really design the process that we want to have, the new re-envisioned workflows, and have technology support those rather than hope that the technology will drive the changes that we are hoping for. Thank you.
So I think it's now afternoon. So good afternoon, everyone. My name is Ken Ricato. As mentioned, I'm a nurse researcher. I spend a lot of time doing clinical decision support. I'm glad to hear that Dr. Ferris really likes clinical decision support. And I'm here to talk a little bit about AI for the health workforce from a nursing perspective. I think I'm going to try to not repeat some of the things that were said previously. So there's three broad areas that I'm going to talk about that I think are really important in nursing as the way I've conceptualized it. So I'm going to talk about workload management and efficiency, mental health and emotional support, and continuous learning and professional support. And these are all areas that I want to talk about how AI is being used right now and some I call it challenges and opportunities. So workload management and efficiency from a nursing perspective, right now the literature says that nurses spend about 80% of their time doing scheduling. So you can imagine that, and AI has been successful, AI research anyway has been successful. I've done some research with a colleague named Carrie Chan at the Columbia Business School, where been very successful in being able to predict what's needed for the workforce and be able to bring that into scheduling. And so there is great promise for that. Task automation, Dr. Gerhard and I think we were on a task automation panel maybe 2 years ago. And there is great promise for task automation. When we think about the role of nurses in things like documentation and billing, we talked about prior authorization in the outpatient setting. It's very burdensome for nurses to free them up to do direct patient care or other tasks. It is important, I think it was mentioned at the beginning, there is research that shows also in nursing that when nurses are free to do more patient care, their time is filled with other administrative tasks. So we need to think about that. AI is promising to do that, but there are issues that we have to figure out. Resource allocation. One of the things that nurses do spend a lot of time, and this is sometimes a system issue, is identifying resources and understanding where those resources are. There's a lot of innovative work being done with things like robots to help with that, and also scanning in supply chain management. Mental health and emotional support. So as many of you know in this room, there's been an explosion of AI-powered mental health apps and chatbots to help. The literature shows that actually is helpful in providing emotional support and reducing stress. Burnout detection, which is, I think, really exciting. So one of the things that I've tried and failed from a research perspective is how to detect burnout in almost real time. There's a team that was just published recently, I think April this year, from Mayo, led by Dr. Wilton, where they created what they call Brownie, which is the burnout prediction using wearable and artificial intelligence, pretty crafty name. Mm-hmm. So basically they just had nurses wear a watch, I believe it was a Garmin watch, that would measure a bunch of physiological signals, but they were able to predict burnout. I think it's important with burnout, some of you might know in the room, that burnout is much harder to treat once it occurs than to prevent. And so I think it's important for us to think about that. And then the last category I'll talk about is continuous learning and professional support. And when I say professional support, I'm thinking about how you can support a nurse to work at the top of their license, to do nursing science. And so there's personalized training, basically competency-based training, which is it's not a new concept, but it's become kind of de rigueur these days, where AI is really good at figuring out where you are in your levels of training and providing you the adequate level of training until you get to the next level of training. And so there's great potential in that, and there's great science being done around that. Decision support, which is the way I see it, designed to provide in the clinical setting at least, support for clinicians to work at the top of their license, free them up to think, to reduce their cognitive burden, to think more clearly about what their training has told them they should be doing for the patient. And so one of the research projects I'd like to highlight is a project that myself and Dr. Sarah Rossetti, who's going to be speaking later today, have done where we actually the task was to predict inpatient deterioration, and instead of trying to model the patient and physiological changes, which we feel is a lagging indicator, once you have physiological changes, you've already started deteriorating, we actually model nursing behavior and levels of nursing surveillance to predict deterioration, and we're able to predict deterioration 2 to 3 days earlier than the deteriorating event. And so I highlight that project because we've had great results. It's under review in a high-impact journal right now, and but one of the things that were really key to it are some of the other pieces that we talk about burnout, where we take information that's already in the clinical workflow, so we don't add any burden to the nurses to add information. We've also made sure it's very explainable what's driving the prediction at any time. And so we've gotten really great results. Risk of mortality for patients lowered by 35% in the intervention group. And so we're very excited about that. And so finally, simulation-based training. That's an area, training is something I think we do very badly in healthcare. And when I mean training, I don't mean education. I mean, as you're doing your work, continuously training people. That's something that when we talk about AI interventions, we're going to need to be able to continuously train people about the new interventions that are coming. And so there has been really great science, not just the sexy VR and virtual reality stuff, but to train people continuously. And so just quickly, challenges and opportunities, and many have been mentioned already, so I'm going to skip over a couple of them. But I think the first one I'm going to start off with is traditionally nursing has been an afterthought in healthcare. And so I think it's really important for us to make sure that nursing is at the table in every aspect in AI intervention. And that's one of the things that I do in my research, is to make sure in our advisory boards we have clinical nurses, we have nurse researchers, things like that. A strong governance, there's this idea, Dr. Levitsky talked about having AI, make sure that we're doing AI for the right purpose. I think a strong governance model, not just at the places that have strong governance, but across the country will be important. And then, so right now I see in things like, in a lot of the large language models, there's a lack of clinical reasoning. And we've done some research when we think about nursing clinical reasoning and thinking about those data that are in the data sets don't necessarily represent what's happening in clinical reasoning if you're learning on EHR data. So how do you develop science to, and people are doing things like knowledge graphs, but knowledge graphs, we haven't figured out how we're going to bring those into large language models. So we need to think about how we're going to incorporate clinical reasoning. And then I'll wrap up with two things. So workforce, in nursing, we have workforce issues where we don't have the right amount of trained AI researchers, clinical informaticians, and implementation science folks. So that's something we have to figure out how we're going to do. And then the last thing I would say is, people ask me to talk about nursing, but I think we need to take a more interdisciplinary approach to these problems. Because, a patient sees a bunch of different people, and we as clinicians work in an interdisciplinary team. So I think it's going to be really important for us to figure out how we solve these problems and not think about it as, how do we get better AI physician tools, better AI pharmacy tools, better AI nursing tools, but just basically how we get better clinical tools and build interdisciplinary systems that those tools can support. So I'll end it there. Thank you.
I do. Thank you. Hi, everyone, and good afternoon. I wanted to thank my co-panelists for such wonderful remarks. I'm Jackie Gerhardt. I'm a family physician from Epic, and my background is that I did full scope family medicine at the University of Wisconsin, inpatient, outpatient, obstetrics, nursing home, et cetera, for about 8 years before starting as a clinical informaticist at Epic. And one of the first things that I get asked is, physicians actually work at Epic? And the answer is yes, but every single day we do slightly different things. And so I'm here to show you a little bit about what the role looks like and also really to be the use case queen. So we've heard a lot about the research and so forth, but I want to get very practical, very actionable on what has been used, what's been studied, and then some takeaways of what we can do from here. So to start, this represents that AI has been around for a long time, period. We've been using it throughout our daily lives, and we would be remiss if we didn't state that we're already using it in many places within medicine. Why it's jumped on the scene so recently is because of the Gen AI. And as Dr. Longhurst mentioned, ChatGPT came on the scene, and our patients started using it, and we're playing catch up. Just a little bit of definition and background. We've talked multiple times today of a few different types of artificial intelligence. All the rage, again, is on generative AI. But I really want to focus on both the rule-based logic and the predictive analytics that have been around, again, for a long time. Rule-based logic is something like a drug-drug interaction or a drug that interacts with an allergy. So it's something that is specifically coded within the system to help you make a decision. Predictive analytics was just mentioned on nursing, for example. So trying to figure out a deterioration index or risk is an example of trying to take information from previously and apply it to try to predict what's going to happen to a patient in the future. And these, again, are in use. And then now generative AI, really, what are the practical ways that we are currently using this within the healthcare system? So I want to focus primarily on 4 things that this can do for clinicians and for patients. So these are tasks that we have to do every single day, and they are not really what brought us into medicine, right? We're there because we want to take care of patients, we want to be able to see things and really make a deliberate decision on diagnostics and therapeutics, while the other stuff that usually takes like 90% of our time just falls by the wayside and into the background. So can that AI draft text for us, summarize things like clinical records for us, translate even, and that could be multiple types of translation. That could be from one language to another, or it could be, for example, putting doctor speak at an 8th grade reading level, which can be really helpful as well. And then task automation. So think of those 4 as what I'm seeing as the first entry points into generative AI that really allow us to do something that allows to reduce burden and address clinical well-being. So here's just a brief history of when things happened. If you're not aware, Epic at least has 297 organizations that are live using generative AI today. So this is not something that's coming in the future. This is here, and we really need to pay attention to how we research it along the way. So intentionally, at Epic, we've been developing, starting with clinicians and creating use cases that intimately help them reduce their burden. Oftentimes, we first think about putting the patient at center and everything else around the patient. But in this workforce crisis, we've heard a ton about how we don't have enough clinicians, about how they're burning out, et cetera. So we really wanted to attack that first. So I'm going to talk primarily just about doctors and nurses today. And we're going to do a rapid fire use case. Here are some of the things we've already discussed that are available now and ones that are coming. In-Basket you heard of, and Dr. Longhurst has printed a really great article on it. I encourage you to check it out. Really good research on what it does reduce and what it doesn't. Same thing with outpatient summaries. There's some good research in Lancet out of the Netherlands that goes through how that helps to summarize notes. And just a picture of what those look like. Oh, one more stat first. So generative AI adoption, someone mentioned this a little bit earlier, even if it doesn't feel, or if the numbers of decreasing the amount of time aren't there, clinicians are feeling this deeply in their bones and in their heart, that they are getting home for dinner on time, that they feel less burden, that it's, in some cases, feels like they're better connected with their patients and so forth. So as we research this, don't forget there's the quantitative side, but also the qualitative side that really is impactful. All right, examples. So first, ambient notes. This is what a typical note template looks like with when you're seeing a patient in Epic. You then can take any EHR, or excuse me, any vendor of voice recognition and put that in to be embedded within the EHR, and it will write you a note. This I've seen in my own practice to be able to actually catch things that I didn't notice before, and so it actually is helping me in my own patient care as well. So a win for documentation burden, but also a win for really capturing the voice of the patients, and patients do feel like they're not only listened to more because you have more eye contact, but also that when they go back and look at their notes, because remember they are a consumer of the record too, that they really feel like their voice was heard. Next example is summaries. This is one example in the outpatient setting where pulling together that complexity of care that we heard about earlier and making sure that the labs, the notes, et cetera, are all brought into one place and that we are being transparent about it. You see there's a little AI symbol in the upper right corner. So that helps the clinician know that AI behind the scenes is helping gather this information for them to then take action on, reducing cognitive burden and so forth. With the UX, you need to make sure you're doing the right UX for the right person, so the hospital summary looks different than the outpatient one. It includes things in the last 24 hours, recent notes from the past few days, ones that are specific to this patient. And then in-basket responses, so the goal here is to decrease the cognitive burden. And as we mentioned, some of this is really just trying to get through the in-basket and increase your ability to get back to seeing your patients, since that was something that really increased during the pandemic, and we see it as yet another burden. And how can we, instead of seeing it as a burden, have the burdensome parts taken away so that we can really focus on the patient care pieces that are there. Coming next and under development is discrete documentation, not just in notes, but also in orders. So you see here that I might have a conversation with my patient about their diabetes, and then it'll show the change in the metformin dosing and even a referral to nutrition that I might have spoken to with my patient as part of their plan. Moving on to nurses. So same thing, they can use in-basket, and as Dr. Longhurst mentioned, RNs have really been seeing great promise with this. And then there's also a few others that are coming up, the AI text assistant, inpatient summaries, and end of shift notes as well. And I'll just give you two quick examples. The first is that end of shift note. So this is live today at multiple different healthcare organizations. And what this does is it brings together what a nurse would typically type at the end of the shift over and over again in the very same format, and brings in discrete information from the chart so that they're not going back and flipping from one screen to another and referencing that information. It's instead brought forward for them. And then ambient flow sheets. Ambient is not just for physicians. Nurses also can use it at the bedside. This is one good example of actually using something that is not AI, so like a macro, for example, for a flow sheet, and how that can actually be a solution in addition to or instead of something that is an AI solution like ambient. So as we've been piloting this in the field, oftentimes nurses don't find themselves explaining their plan of care or explaining and doing sort of verbal discussion back and forth. They're used to documenting in flow sheets. So how do we make sure that we're developing the right tool for the right job within AI? So I'm going to, before your lunch break, I want to add 5 different takeaways that I think I heard from our panel, and I think could be things that NAM could definitely do in the future. So the first one is use the right tool for the job and make sure it has the right fit. So we heard about automation versus AI. Definitely make sure before investing in AI and spending the cost that it might be that you don't already have a tool that you can use that could automate something that might even be better. Second is choose and create interventions and research while you're going. We as an academic community oftentimes think about doing research first and then implementing something afterwards, and we heard about implementation science today, and I think all of us feel that implementation science is so critical to making sure that you're not just putting a technology into place, but you're actually making it adaptable to the people that are using it. Third is emphasize governance and transparency. So as you know, many shiny objects will come to your door and you'll have to decide which ones to choose. If you have a good governance structure about what it is that you're looking for and your key priorities, maybe it's clinician burnout, and that would be one that is well studied for you to have as the core of your governance, and then what AI tools actually help benefit that. Then fourth is clarify your message. We've heard, and I can speak to it from the side of both the health system and the vendor side, we've often heard conflicting feelings around seeing patients. What I mean by that is, on the same breath as saying we feel burnt out and we just want to get back to patients and see our patients and look them in the eye, we also hear things like ambient that say, yeah, but I don't want to just see one more patient. And if you think about those two messages and combining them together, there's a little bit of a dissonance there. So how do we as a community figure out how to communicate on our needs within using AI and on our needs within well-being? And then lastly, number 5, be ready for more. The examples that I just gave today are very much use cases that are pretty simple and don't have a ton of risk. And I think we heard that really one of the opportunities here is to have clinical decision support and to potentially help decrease misdiagnoses or improved treatments. And so that's coming, and I would encourage us to start with these types of use cases that are perhaps lower risk as we are anticipating further ones. Thank you.
Thank you very much to all the panelists. So for those in the room, we're going to keep you hostage for about 20 minutes for a Q&A. We're not quite ready to go to lunch. And for those of you who are on Zoom, there's a mechanism for you to enter your questions, and then the staff here will be sharing those with us. As you contemplate your questions for the esteemed panel here, I thought I would kick it off with one of my own. We've heard multiple different ways of applying potentially AI through the lens of both inpatient, outpatient care, various different healthcare professionals. And, and I think one of the things that Dr. Gerhardt just mentioned too is this issue around the reality of what's the financial model, right, to pay for this. I think that's sort of one of the elephants in the room that we need to deal with. Because margins are shrinking in hospitals, many hospital systems are actually in the red. So how do we become that early adopter that we heard about from the plenary? So I'd like for each member of the panel here maybe just to address this question about what's the financial model for incorporating AI into healthcare. And after that, open it up to the floor and to the Zoom audience for additional questions. Thank you.
I can start, and then I know you'll all add on. So,
pile on.
Yeah, please pile on as much as you can. This is a huge issue, and it's definitely an issue around well-being as well. There's often a really good narrative around what does it look like to see one more patient, or what does it look like to decrease your population health costs, things that are very much hard ROI. And there hasn't, in my opinion, been enough discussion around the ROI of clinician burden itself. I think there have been multiple discussions around what's the cost of losing a physician or a nurse, what is the burden of having them have decreased safety when they make a medical error, and so forth. And so I think putting much more discrete financials around that is important. Then that's the general topic. Then more specifically, each one of these AI models does cost money. There's a cost and a compute factor to each one. And so as you're looking to implement it, it's really using the right tool for the right job that is actually going to be cost effective. So there might be something, again, that's not AI that you could use. And thinking about the end user is key. If you're trying to help improve your physician well-being, what tools are you giving them? What about the nursing well-being? It's partly about efficiency, and that's one hard metric that we can get. But it's also about things like cognitive burden and decreasing the load and making sure that you're actually getting good care to the right patient at the right time. So figuring out actual dollar signs in front of that is important. And the last thing I'll say, every single one of those 297 organizations that I mentioned before that's using Gen AI had to have a use case where they went to either their board or their executives and said, hey, we want to implement this. Here's the ROI behind it. And so I would just encourage you that people have come before you. Make sure that you go ahead and use the research that's there already.
Yeah, so I would add to what Dr. Gerhardt said similarly that there's a woman named Jane Engelbright who was the CNE, Chief Nursing Executive at HCA for a while. And I saw her do a magical thing I'd never seen anyone do before, which was get a large healthcare system to put lots of money into nursing to do computational-based research. And what she did was literally just a back-of-the-napkin calculation of how much you're spending on nurse turnover. And so to Dr. Gerhardt's point, I do think that there are ways that we haven't thought about how we spend money in healthcare, that we need to sit down and think about it and operationalize it. And I'd also add that my background is in data science and software engineering, so I know people at some of these fancy AI companies, and they have problems figuring out how to think about how to charge for these things as well. So I do think that some of this is just having issues of trying to think about new paradigms and how we do it as well, that we need to figure out, that we're not so good at in healthcare as well.
So absolutely agree with all the points that have been made. The way that we think about this at the AMA, and we've put a framework together we call Return on Health, is thinking through what we call the value equation. Often when you present this to your board or your E-team, the first question is how much does it cost? And of course, cost is part of the value equation. And then there's all of the other aspects. I think about it in terms of the quintuple aim. So the clinician experience, the patient experience, quality outcomes, and then of course, impact on equity. And so as you think about each of those buckets when it comes to whatever technology that you're evaluating, we've been talking a lot about ambient. One of the last things I did in my CHIO role is work on signing the contract for our ambient vendor, and that's exactly how we presented it. And that was the process we used as a healthcare institution. In our governance model is for all technologies, we needed to evaluate it in all of those buckets. And it's gonna look different depending on what problem you're trying to solve. But if you think about the clinician experience and you start to measure things like turnover and clinician satisfaction and all of these other aspects, then you start to build a more robust process for evaluating your technologies, and you can demonstrate the value. And the final thing I'll say about that is we are often not great about measuring baseline. And so I would encourage you, whenever you're presenting this, to recognize what your current state is, so that as these technologies get implemented, we actually are able to show the impact that they had in each of these categories, and we're able to demonstrate the value.
Thanks for the thoughtful comments. I'll just add that I completely agree with Margaret that on the local level, it's about the return on health and measuring the quadruple aim. But I think at a national level, somebody alluded to solving the right problem. And it reminds me of a 2018 article we published looking at the length of notes in the US and across other countries. I see our colleagues from Canada here, where the median physician note length is about 600 characters, compared to the United States, where the median note is about 4,000 characters. So what have we done with these AI scribes? Well, we've recreated sort of the old model of let's get a fully compliant note that we can use to bill every CPT code under the sky. And it works, but it doesn't help us solve the root problem. And so this is a generational opportunity for us to think about how we change this. Dr. Seema Verma, when she was leading CMS in 2018, actually started an initiative called Patients Over Paperwork, where it was a reduction of documentation required for CPT billing, which was a good start, and it cited that paper that we had written, but I think we have a long way to go. Dr. Ferris mentioned this company that spun out of Stanford 10 years ago, helping to prioritize children with autism for services. And I'll tell you as an advisor that the technology works really, really well, and the company is going underwater because there's no financial model to sustain it. So we really have to rethink our health economics and incentives so that we can take advantage of these new technologies to solve the problems that do matter.
We'll go ahead and take questions from the audience. Is there a mic that'll be passed around? Wonderful. There's actually that lady in the back in the green had her hand up first. Thank you.
You as moderator, because I could never pronounce your name. But you did mention about elephants in the room, and I have Alzheimer's memory. So one of the things that I'm going to be asking, not to get an answer right now, but people to think about, you can talk among each other and with the panel. So in looking at the doctor-patient and RN-patient collaboration in delivering care, because that's important. One of the things that one of our big healthcare people started about, 25, 30 years ago, call centers. And call centers were good ideas, in my opinion, on paper. But how can AI address the issues associated with call centers? Health insurers practicing medicine. I'm not talking about anything about the murder that just happened, because that's completely different from what I'm talking about. Practicing medicine without a license. And peer-to-peers are being done by non-clinical people and taking up a lot of time with peer-to-peers from non-clinical people. How can AI address that issue? And finally, something that everyone that has had a medical record, whether you're a physician or patient, correcting errors in the medical record. So those are things that I would like us to think about and talk about amongst ourselves and with the expert panel. Thank you for your time.
A lot of questions.
Anybody want to take on one of those?
You want to go?
I feel like I've been starting. Does anyone else want to start? Otherwise, I'm happy to.
You can start.
All right. So I'll take on the different three. So starting with call centers, I do think AI is already helping with this quite a bit. So you can imagine that in many other industries, there's automation. So automation is first, and then there's also chatbots, which you've probably seen and used with many of your other apps as well. Many organizations are already using chatbots as part of their call center infrastructure, and it's going to be even coming more so. So for example, right now as a patient, you can use your phone using SMS text message to send in a text saying, I need to cancel my appointment, or I would like to see my physician. And then the chatbot can respond and say, oh, that's really nice. It looks like there's time next week, Tuesday. Does that work for you? Press 1 if yes, 2 if no. And so this stuff already is existing and really helping patient care. I think it's going to become even more intelligent as the models improve. As for health insurance, that does have some AI in it. We've seen some drafting of things like denial letters and so forth. But I actually think that's one, back to the viewing this nationally, I think that's one that we can solve even before using AI, or potentially even without AI, in that if we can just come up with a way, at Epic we call it payer platform, but a way to share the message that this chart says with the insurance company so that you don't have a denial or you don't need a prior auth in the first place. Just that information sharing back and forth can really be meaningful even without using AI. And then for correcting errors, yeah, I really think AI is the future for this. I am humble enough to know that I, as a physician, am very human, and that, to the points made earlier today, I will forget something that I've been taught. And I'm hopeful that as we go forward in diagnosis, treatment, et cetera, that AI is part of the role that we are playing and doing for every patient, because they're going to use it themselves. So I'd like to be part of that care team that helps them use it.
Thank you. Anybody want to add anything, or we'll take another question here? Let's do one more from the audience here in the room, and then we'll see if there's any questions available online.
I have two quick unrelated questions. Great panel discussion. Thank you. A comment came up about refining the business case. You know, do you know if anybody is doing that work, that, you know, we can have one calculator that, you know, decrease burnout by 10%. It translates not just to decreased nursing or physician turnover. We, you know, from studies, the quality and safety outcomes improve, which are attached to this sort of financial improvement, patient experience, discretionary effort in terms of our views. I think that would be a real, you know, great opportunity when we're pitching these things. And then unrelated, I'm not very familiar in Louisiana with the unionization movement. I was just wanting to get a sense, do you sense whether that is hindering experimentation with low-tech, high-tech models of care within nursing, accelerating, or no difference at all? So, thank you.
I can start. So I live in New York and worked in New York, so I'm very familiar with the union movement. I would say that it's hard to say because it is highly variable across the United States. I do think that what I've seen just in my personal research is that the union movement has allowed for people to pause and think about some aspects. We talked about some of the deleterious possible side effects of you know, bringing in kind of private equity and things like that, and more business into healthcare, and I think the union movement has helped with that. I have also seen on the other side where research and innovation has been slowed down. So I think it cuts both ways, basically.
Yeah, your second question about labor impact, I think, is actually very, very pertinent. At the recent Chicago meeting we were at, you could almost divide the room into how quickly they were moving based off of feedback from labor and whether or not they had organized labor concerns. You know, and Ken, your point's well taken that sometimes slowing down and considering carefully is the right approach. I think one thing we haven't talked about on this panel, I'd love to hear about the rest of the day, is the importance of retraining our workforce. Dr. Ferris gave the example of, you know, moving from 300 to 150 coders at one physician group and the positions. There was a previous question about the call center, and I would venture to guess that in 3 to 5 years we won't have call centers that are staffed, you know, exclusively by humans. There'll be a first call resolution of 100% because everything will be answered by a voice-assisted bot. But the implication, again, is that we have to figure out how we're going to retrain that workforce and make sure that there's opportunities for them to help in different skills and different positions. So this is a really incredibly pertinent. I would even go as far to say that Dr. Ferris predicted, and I agree, that over the next 7 to 10 years, practice of medicine is going to change substantially. And I would challenge the hypothesis that we'll need as many primary care physicians. It may be that our mid-level providers with augmented intelligence are operating at the level of the best primary care doctors. And so we may need to rethink how we're educating our future clinicians and workforce as well.
And I'll add specialists too. I don't know if we're going to need as many of those.
Are there any online questions?
So just to build off of that training comment, a question asking the panel to provide their perspectives on the roles and responsibilities of health profession schools and faculty to prepare future clinicians to optimize AI.
I can jump in. I think it's been stated by several people that we're going to need to absolutely provide training for all of our colleagues. There is a lot of fear that AI will replace us, and as one of my colleagues always says, I don't think AI will replace us, but doctors that are not fluent in AI will be replaced by doctors who are, because it is going to be an integral part of how we deliver care in the future. And there's a few opportunities. First of all, we're going to need to have some very clear education for all of our trainees, but also for all of us that are out of training. This will continue to evolve, and we will need to understand maybe not the inner workings of how every AI model is functioning, but at the very least how to interpret their output and how to integrate it into our care delivery, and how we change the workflows and the way that we see patients. And then there's also a huge opportunity in medical education, which we talk about a lot, because AI is, as was stated, very good at really understanding where people are at. So having precision education for our trainees that is tailored to their needs and addresses the gaps in their training will be a very important concept as we move forward. And as we think about the future world, we often talk about this education and practice being intertwined together, where we will continue to learn and obtain new skills as we see patients.
Yeah, I would just add that I think one thing that I've seen in my travels is that from an educational standpoint, we'll need to know how to think more strategically about AI, and it's not always, the answer is not always having more AI expertise. So I do think that that is something from an education perspective we need to think about.
I'll just add, Dr. Lozovsky is absolutely right in thinking of all the different parts of medical education. I think oftentimes we, depending on who we are, we center ourselves on maybe undergraduate medical education or thinking about continuing medical education. But 2 weeks ago, there was a Macy Foundation event where it was a closed meeting, 50 people, top educators and boards of medicine, that we really came up with a bunch of ideas for how to reimagine medicine education, just like we're thinking about reimagining medicine in the future in the next 10 or so years. So look for that, because I think that'll be a good piece to see.
Great. Well, we're at time. Sorry we didn't get to everybody's questions, but at this point, we will break the live meeting for lunch. Thank you.